Unfortunately, we're facing some challenging times right now. Obviously, on the forefront of everyone's mind is COVID-19, and that has significantly affected oncologic practices across the country and the world. So for instance, being at a big, large comprehensive cancer center, many clinical trials have been put on accrual pause to limit extra visits for the patients and also to limit touch points for our clinical and research staff. I think that has been a challenge and hopefully will be a short-term issue as we're starting to come out of our darkest time with COVID-19 and things are ramping up again. I know our center is slowly starting to open up some clinical trials. Now, there are many other considerations, one of which has been hospital beds and ICU beds and ventilators in particular. So our center has made a real effort to try to limit hospital admissions of patients that don't absolutely need to be admitted. That includes considerations of inpatient regimens, that includes clinical trials with inpatient regimens, and that includes even the thought of administration of drugs that have high potential for toxicity that might lead to the patients requiring inpatient admission to the hospital. This really affects how we think about cytotoxic chemotherapy agents. In some diseases, the myelosuppression can be very pronounced and very long-lasting, and febrile neutropenia risk is very high. We're fortunate in prostate cancer where that risk is not as high with the single-agent docetaxel and cabazitaxel chemotherapy. However, it still happens, and it needs to be a consideration. And in my practice, it is certainly a discussion that we have concerns that myelosuppressing patients might increase their risk of COVID. And in that situation, when we have good alternative treatment options, we're discussing with the patient, and oftentimes we're choosing other treatment options. So if we were to insert the COVID discussion into this patient that I just presented, I already find enough reasons to use radium-223 and to save docetaxel for later. But just another consideration would be the fact that I think the myelosuppression that radium-223 causes is at a much lower level and a much lower risk than with chemotherapy like docetaxel. And with that consideration, I think that emphasizes the fact that this patient really, probably gained the best treatment at that time with radium-223. There is one issue that wasn't discussed in this case, and that's the use of bone protective agents. We all know that there's very strong data to support both denosumab and bisphosphonates for use to prevent skeletal-related events and symptomatic skeletal events in those who have bone metastatic cancers. Certainly that includes prostate cancer, castration-resistant prostate cancer. There's also data for use of these agents in patients that might be at high risk for osteoporotic fractures. And certainly men with androgen deprivation therapy for prostate cancer are at higher risk of osteopenia and osteoporosis. And there's data to show that use of these agents can prevent osteoporotic fractures. There's also some data from some database and retrospective analyses that show that these agents don't cause antagonism with radium-223, and they may be beneficial in combination. So that is certainly a discussion I would have with this patient is, would we and should we, I personally would, add either a bisphosphonate or denosumab in that setting, and I probably would use denosumab as my treatment of choice in this situation.